Good morning, everyone, and welcome to the Florida Healthcare Association's webinar series on the patient-driven payment model. I'm Melanie Motiska, Quality Improvement and Education Manager for the Florida Healthcare Association. Before we begin, we would like to thank our title sponsor, MedPass, for their support and sponsorship. MedPass is a provider for long-term care documentation, e-solutions, reference tools, policy and procedures, and your source for MDS resources. Also, a special thank you to our supporting sponsor, Thrive Behavioral Sciences, who provide psychiatric evaluations for both medical management and talk therapy, diagnosis confirmation, and treatment recommendations for residents. So please take a moment after this webinar to visit their websites to learn how MedPass and Thrive Behavioral Sciences can help you prepare for PDPM and meet some of your center's needs. Thank you, MedPass and Thrive Behavioral Sciences, for sponsoring today's program. Let's get some housekeeping notes out of the way so we can get started with today's great program. Due to the large number of participants, all attendees are muted. We encourage you to use the computer audio rather than a telephone to maintain sound quality for today's presentation. We encourage you to ask questions throughout the presentation by typing your questions into the question box. The slide you see now shows how to submit a question using the question box. You may also email me directly at mmotiska@fhca.org with your questions. Please note that the Handouts tab on your control panel is where you can download today's handouts. We will compile a question and answer document and make it available through FHCA's various communications channels. This webinar is being recorded, and an online archive will be available in the members only section of the FHCA website. If you have a colleague unable to join us today, please encourage them to view the recorded webinar. I would now like to introduce today's speaker. Carol Maher is a registered nurse with over 30 years long-term care experience and has worked in long-term care in many roles. Beginning as a nursing assistant, she later became a charge nurse, nurse manager, and then RNAC. Most recently, she was the Senior VP of Utilization Services and Director of Reimbursement for large multi-facility organizations. She has worked as one of the gold standard nurses for MDS 3.0, serving on the RAP work group to prepare the way for the CAAs for MDS 3.0, and participating on a number of technical expert panels related to MDS and care planning. She has been a speaker at AANAC and AHCA national conferences, as well as many state organization presentations. She is also a frequent author of articles related to the RAI process and PPS. Carol served as a member of the AANAC Board of Directors for 9 years. She is presently serving on the AANAC Expert Advisory Panel and as an AANAC Master Teacher. She is the author of Long-Term Care MDS Coordinators Field Guide, HCP RO 2016. Thank you very much for presenting today, so let's get started. Today's presentation is titled Strategies for GG ADLs for PDPM. And with that, I'd like to turn over the presentation to our presenter, Carol Maher.
Welcome, everyone. And today we're going to talk about strategies for Section GG, the ADLs for the patient-driven payment model. And I know that this is of great interest to you. The PDPM payment is based on clinically verifiable resident characteristics. Mainly, those characteristics would be the ICD-10 coding and the Section GG functional scores. These two processes are the most important in affecting payment under PDPM. If I had to say which is the most important, I would say that the ICD-10 coding would be a big focus because that will affect most all of the components of PDPM. And second, and a close second, is Section GG. So we're going to touch on both today. I'm going to just do a little brief talk about ICD-10. In October 1st of 2019, the MDS, of course, is updated as it is every October, but this October is a real focus on preparing for PDPM because that is the day that we end drug-4 and begin PDPM payment. So in Section I of the MDS, in I-20B, which we don't have an I-20B right now, in I-20B, we will enter the principal diagnosis for the resident's stay, the main reason they're in the facility for skilled care. And that entry in I-20B will then map to the therapy components and affect the payment. And so this is a very critical process that you should probably start practicing now, looking at the medical records and deciding the very one and only principal diagnosis for the main reason for the stay. And it will be entered in I-20B. So we presently have a number 14 in this list above it, and we have an I-20A, 14, and I-20A will go away, replaced with I-20B, where we will enter the principal diagnosis. And from that principal diagnosis entered in I-20B, there has been mapping developed where the residents will be classified into a clinical category based on that primary diagnosis, and it's mapped to the PT, OT, and speech components. And it can be further adjusted. If you look at the mapping files, some of the diagnoses will have a default category, but the category could be adjusted depending on whether the resident has had surgery during the prior 3-day qualifying stay. For example, someone who has a hip fracture of the neck of the hip, neck of the femur, it defaults to non-orthopedic surgery because not all fractures are repaired, but it gives the option of either moving into a surgical category or a joint replacement category. And so again, the Section J that will be added in October will allow that further mapping. And this is the link to the website where you can download the mapping and take a look at that. All right, so in the PT and OT classifications, it's collapsing of the 10 possible mapping clinical categories, it's collapsing them into 4. So on your left-hand side, you'll see the 10 possible categories when you're looking at the mapping in the CMS mapping file. And so there are 10 possible categories, and they each can map to PT and OT. And so you can see, for example, under medical management, it includes acute infection, cancer, pulmonary, and cardiovascular, and coagulation. And so they're collapsing them to equal these 4. There is an 11th category that you can see on the mapping that's return to provider. And that's the one you don't want to see because that means it won't map, and you really cannot use that diagnosis as a principal diagnosis. There are 75,000 or nearly 75,000 ICD-10 codes, and they each have a mapping clinical category behind them. And so this would be something you want to get familiar with. So the 4 PT and OT components would be major joint replacement or spinal surgery, other orthopedic, which does include orthopedic surgery like an ORIF, non-surgical orthopedic, musculoskeletal, medical management, and non-orthopedic surgery, like if they had their gallbladder out or had a cabbage done, or acute neurological. All right, so the major joint, the 4 categories, so you can see on your left, the 4 categories are further broken down into the GG functional scores. And so you can see that in the middle column there, that it's breaking each of the 4 categories into the functional score. 0 to 5 gives you a TA, 6 to 9 gives you a TB, 11 to 23 a TC, and so forth. And for each of those, it further breaks it down into a case mix index. And that's how you're going to get your payment established for your PT and OT component. So on the left-hand side, you'll see under the clinical category, the 4 components, the joint replacement, other ortho, medical management, and non-orthopedic surgery. And then you'll see under the GG functional score where you'll find your ADLs, we call them now, but they'll be called a function score in October, broken down. And then from there, once you find your GG score and your basic clinical category, then you'll have a PT case mix and an OT case mix. And those multipliers will multiply times your PT base rate or your OT base rate to establish your payment. So for the GG, so this is the end split, mid split, however you want to look at it, that this is going to further break down those major components. We have our section GG. So we're no longer going to use the late loss ADLs in section G that we've known for forever, since 1998, I suppose, or even earlier. We're now going to be focusing on section GG. And it's upside down from section G. In section G, if you're independent, we get a 0. If you're totally dependent, you get a 4. In GG, if you're totally dependent, you get a 0. And if you're completely independent, you get a 6. So it's upside down and backwards from what we're used to. And the other thing that's very intriguing about the functional score is there's not a direct linear relationship to the payment. Under RUG 4, we know that the more dependent the resident is, the more money we get. So if they need extensive assistance of 2, we're going to get more payment than if they're independent. So if they have a score of a C for a therapy RUG, we are paid more than if they have an A. But in PDPM, there's not that direct line. And if you look back at that the therapy case mix, you'll find that sometimes the highest paying one, they're completely independent. The lowest, one of the lower ones is the totally dependent. And so, but it's different for each one of the component scores. But in nursing, it will continue to be more dependent the higher the payment. So there's not really a direct linear relationship that we should say, oh, we want them to look more independent or we want them to look more dependent. You want them to look accurate. And we have to be coding this as according to the resident's actual function. So this section GG is to calculate the functional splits for the PT component, the OT component, and the nursing components of PDPM. I'm going to talk about the REI manual instructions because, of course, as now, the payment will be established from all the data entered onto the MDS assessments. And so beginning on October 1st, we have to be following the manual instructions that will be released in May, that will take effect in October. And they are the rules that we follow for coding the MDS, which will result in a payment. So presently, here's what it says. It says, so steps for assessment for section GG, which is our focus today. And it says, assess the resident's self-care performance based on direct observation, as well as the resident's self-reports and reports from qualified clinicians, from care staff or family documented in the resident's medical record during the 3-day assessment period. Now, CMS anticipates that an interdisciplinary team of qualified clinicians is involved in assessing the resident during the 3-day assessment period. So I want you to think about that. I mean, right now, when I talk to facilities, they'll often say, oh, GG, that therapy does that. Or therapy will say, oh, no, nursing does that. And it's not one person's role. According to CMS, it needs to be an interdisciplinary team of qualified clinicians, and it needs to be based on an assessment. So this is not data collections from your CNAs like we do for section G. This is us doing direct observation of the resident for every one of those GG items in the first 3 days of the stay and the last 3 days of the stay. So for GG, the admission assessment period is the first 3 days of the Part A stay, beginning with the Medicare start date. This is reported on the 5-day, which in October they're going to refer to as the initial payment assessment. And so even if we use day 8 as the assessment reference date, the days that we're looking at to assess the resident for their performance are days 1, 2, and 3 of the stay. So it's the first 3 days of Medicare. Now, the very first week of October, we will be required to do an IPA, or an interim payment assessment, for every resident who has been on Medicare in September and continues to be on Medicare in October, even October 1st and beyond. And so they will need something called an IPA for that very first week of October, with an assessment reference date between October 1st and October 7th. So you need to be prepared for this, because you're going to need to do Section GG assessments, even though it's not the first 3 days of Medicare. In an IPA, the assessment window is the assessment reference date of the IPA and the 2 preceding days. So the 2 days right before the ARD and the ARD will be when you need to assess the residents. So be prepared. October is going to be very busy. So remember that the definition said it's an assessment done by qualified clinician. So what's a qualified clinician? The REI manual says a qualified clinician are healthcare professionals working within their scope of practice and consistent with federal, state, local law and regulation. So basically this is saying it would be someone who can assess. It's an assessment. In most states, for nursing, that would be a registered nurse, and for therapists, it would be registered therapists, the speech therapist, a occupational therapist, a physical therapist, but not CODAs, not PTAs, because they're not qualified clinicians who can assess. So these are who should be doing the assessment according to the REI manual. And when you're doing the assessment, residents should be allowed to perform the activities as independently as possible, as long as they're safe. So in other words, we don't just take care of them. That's why I would not assign this to a CNA, because they just help the resident, which we want them to help the resident, but they're not always encouraging them to be as independent as possible. So this is where the assessment comes in. How much can they safely do for themselves? And when we look at the ADL, the GG definitions, it talks about how much help is a helper giving. And a helper is defined as facility staff who are either our direct employees or they could be contracted. So someone like therapy staff or nursing agency staff, but it's not including individuals that are not compensated by the facility. So they're not talking about private duty caregivers, private duty nurses, student therapists, CNA students, or hospice, because they're not paid for. So we're only looking at facility staff or contracted staff. Now, sometimes therapy will write it's modified independence instead of independent if the resident uses a mobility device, but for Section GG, an assistive device does not count against the resident. So if they're independent with their walker, they're independent for coding GG. And what they really would like in this first assessment is the resident's usual performance during that first 3 days, but they want to know their usual baseline ability before they benefit from any treatment. So they don't want you to put their most independent or their most dependent. They want you to do an assessment to see what they're really capable of, what's their usual in that very beginning of the stay. And again, it has to be an assessment done by staff members who are allowed to assess in your state. So the assessment window for the 5-day is the first 3 days, and it says that it's got to be based on a clinical assessment of the resident's performance that occurs soon after admission, and it must be completed within the first 3 calendar days of the stay, starting with the moment that their nose comes through the door on Medicare and ending at 11:59 p.m. on day 3 of the stay. So the assessment has to be completed. If they come in Friday evening, it's got to be done by Sunday evening. So again, we're looking at only the first 3 days done by a qualified clinician. And for the IPA, we're going to look at the ARD and the 2 days preceding the ARD. And again, just another reminder to be prepared to capture these GG items that first week of October so that it doesn't take you by surprise. So in the IPA, and the IPA typically in PDPM is done when we believe that the resident has had a change in their care, could be a clinical condition or needing special treatments, where we would like to do an assessment to change the payment. So basically in PDPM, the 5-day initial assessment could, the HIPS code from that could pay the entire Medicare stay, but there are going to be times in many residents that their health changes. Maybe they've had an ER visit, maybe they've had a health scare in the facility that we're treating them instead of sending them out to the hospital. Maybe they've had an interrupted stay where we think they now need additional services that will require additional reimbursement for us, and we can do this interim payment assessment. Anytime we do an interim payment assessment, not even just looking at those the first week of October, but anytime during a Medicare stay after October the 1st, when we think that they would qualify for a payment change, we would do an interim payment assessment, and it has a column 5, which is the interim performance, which again is looking at the ARD in the 2 days before that for each of the GG payment items. There are way more GG items than these. There are 22 altogether, but only these are the ones that affect payment, and so the IPA only has the payment items on it. All right, so we're going back to what does CMS expect with GG. The admission functional scores are to reflect a resident's admission baseline status, and they're to be based on an assessment, and the score should reflect the resident's status prior to any benefit from interventions. So they want to know, before we made them better, how bad did they look when they first got there? And so this is their real baseline. So it's before treatment. It says they want them to occur when possible before any treatment interventions, so we can see their real baseline. Even if the treatment did start on the day of admission, and treatment will start on the day of admission, it doesn't mean that you can't do the GG. They, often residents don't benefit right away. So if we put someone on therapy on day 1, they probably are not going to be changed on day 1, but by day 3, sometimes they are improving. The same with nursing treatments. Maybe I'm giving them some medication, and they have an infection, they get a medication, they're not going to get all better on one day, but by the 3rd day, they could be feeling better. So that's why they want this done as close to admission as possible, so we can see the real baseline before we made them better. So think about how you can accomplish that. And here's another big thing before we even get into what we should do. It has to be based on the resident's performance. You're not going to record the staff's assessment of the resident's potential capability to perform the activities. It has to be based on an assessment where the resident actually performed these GG functions. Right now, very often therapy is completing a care tool in their therapy software, and the care tool allows them to extrapolate what they think the resident's able to do using their clinical judgment. And so what the therapists are entering is allowed on a care tool, but it is not allowed in GG. However, often the MDS coordinator is just importing the therapy software into the MDS software, and it's pulling that care tool, those care tool responses right into GG, and the therapists have not actually assessed, excuse me, the resident's performance. So you have to be very careful in doing that. We need to make sure that we're not using any extrapolation, we're not using professional judgment, that we are actually assessing the resident based on the resident's performance. So how can you accomplish that? What would be some strategies? So first of all, I'm going to suggest that you've talked to your center, to your MDS staff, to your therapy staff, and talk about how they are collecting this functional status on the discharge and on the admission assessment. How are they actually collecting the data? Are they having the resident do each of these activities? Often I hear from therapists that their software won't let them close the case until they put an answer in. So they're just putting in an answer so that they can close their software, and there hasn't actually been an assessment. Now they're using their professional judgment, which is okay, but it's not okay on GG. So you need to look at opportunities for improvement. How can we make sure that there's truly assessments done? Are we assessing residents on the nursing unit as they get there shortly after admission? And are we assessing each one of these items on therapy evaluations? Not everybody gets therapy. So make sure that this important process is not just done by one person. It can't be on one person's shoulders. They're not there 7 days a week, 24/7. This has to be an interdisciplinary team. Does your MDS coordinator simply import or refresh the information in to the MDS from the therapy software and just think that the assessment's been done? You can't assume that. All right, so make sure that you have a team approach to collecting the GG assessment data that includes nursing, collecting the data, and therapy. And often we need to look at the therapy software to find out from your therapist which of the data was actually assessed, and we have to look at, it has to be assessed and actually documented in the medical record. Since this is going to be a payment item, I can't imagine that on a Medicare review, a simple number in a box is going to be enough. I think there most likely is going to need to be at least a little bit of a narrative showing what the resident can do. All right, so let's talk about the section GG coding. All right, so again, we're looking at on the initial assessment, the 5-day, every Medicare assessment on the 5-day, you need to answer every single admission performance item. And there are like 22 of them. And you need to set at least one discharge goal. And you can have dashes in that second column, but not the first. If the resident on the end of Medicare discharges back to the hospital, has an unplanned discharge, or dies, then the GG is going to be skipped, but you always do a Part A PPS discharge unless the resident has died while on Medicare. But if the resident does not physically discharge unexpectedly, you will also need to capture the section GG data on the Part A PPS discharge, and this is used for multiple quality measures right now, including that new outcome measures. All right, so what do these scores look like? All right, so if I'm going to assess a resident, a 6 is independent. The resident does it completely by themselves, no help from a helper. They can use a mobility device or an assistive device, but nobody needs to help them. They're completely on their own. We didn't even need to come to work today. Yep, right? Number 5 is setup or cleanup. And this is probably where more of your residents are than the number 6. And this is, they could do it themselves, but the helper has to help them get ready for it. So they have to bring them something, hand them something, set up the whole process so they can do it, or they have to clean up after them. Something that comes to the top of my mind as a nurse, I'm thinking of, I have a brand new person coming in from the hospital, and we put them into bed, and we're getting them ready for bed that evening to go to sleep. And so we're saying, can I help you with brushing your teeth? I bring them their water, I bring them an emesis basin, their toothbrush, their toothpaste, and then the resident sits in the bed with a bedside commode, brushes their teeth, bedside stand, brushes their teeth, and uses the emesis basin and all of that for the teeth brushing, and then washes their face with the washcloth I brought them. And I take all the equipment away, dump it, clean it up. So I have done the setup and cleanup, even though the resident brushed their teeth themselves. So the code would be a 5, not a 6. So other examples of setup or cleanup is pulling up a bed rail so the resident can change their position, or bringing the wheelchair in and locking it close to their bed so they can transfer out, or handing them a slide board. So I'm setting it up, or I'm cleaning up so they can do it. A 4 is supervision or touching or contact guard. So to me, this is a combination of supervision or limited assistance. For nursing, therapy usually calls this standby assistance or contact guard. So we're combining a number of items, but there's no lifting involved. We can touch them to steady them, but no lifting. All right, so it could be cueing and or touching, and it doesn't need to be the whole time they're doing the activity, but sometime during the activity, they did need cueing or oversight or touching. If I had to do some lifting, now we have the choices of a 3 and a 2. So 3 is partial moderate assistance, and that's when the helper is going to have to lift or hold or support some of their trunk or limbs. But in this case, the resident does more than half, so the staff member does less than half. The therapy usually breaks their assistance down to min, mod, and max. And min usually means the therapist does less than half. The resident does more than half. So it's usually around 25% that the therapist is doing. And mod means 50-50. So this will definitely be where min assist would fall. And mod might also fall if the resident does a little bit more than half and the staff member does on the lower side of 50% instead of the upper side. If the resident needs more help than that, substantial maximal assistance, where the staff member is holding or lifting or supporting trunk or limbs and doing more than half the effort, then it would be coded as a 2. Substantial maximal assistance. And again, each one of these is going to factor into payment. So the difference between a 3 and a 2 is important when you're looking at this. So we have to figure out who did more than half. So again, therapy's max is going to fit here, and mod could as well, depending on who did more than half. Then we have a 1 for dependent, and dependent is where the helper did it all, the resident didn't participate. However, there's a second definition of dependent, where it's when they need the resident needs the assistance of 2 or more helpers to complete the activity. And the way that CMS has described this is even if the second helper is there just in case of and is not even touching them, you would code them as dependent. CMS has done a couple of YouTube videos on Section GG, and during the YouTube video, the presenter talks about therapy walking someone down the hall with their hand on their back while the resident uses a walker, and someone's following along behind, an aide following along behind with a wheelchair in case the resident gets too tired or knees start to give out. And they call that dependent for walking. So even though one of the people wasn't touching the resident and the other one wasn't doing any weight bearing at all, the resident would be coded as dependent. And then they also have 4 possible codes if the activity was not attempted at all, because there are going to be some people it's not safe to assess, when sometimes residents just are not up for it. All right, so sometimes a resident will just refuse to do some of the activity, and if they refuse, the code is 7. Of course, we don't want any dashes in any of these items, so it's nice to have these options for when it did not occur that do not require a dash. All right, so 7 means they refused. 9 is it's not applicable. So when would something not be applicable? It wouldn't be applicable if the resident couldn't perform this activity before they went to the hospital for the 3-day stay. So before they got sick this time, or they had exacerbation of like a COPD or a CHF, or they had an injury, they fell at home, or they broke a bone, or they had some kind of injury. So before that happened, could they do it? And so if they couldn't do it, it's not applicable. I'm not going to test it now. And the example off the top of my head is someone with bilateral amputations. Say they had bilateral amputations for the last 3 years, have had no prosthetics, and so the amputations are of their legs, and so they have no ability to walk. They're getting around just fine in their wheelchair at home, and so they haven't been walking for 3 years, and so now they've had a health concern, been in the hospital 3 days, coming to us for care. There's no need for me to try to measure their ability to walk. They weren't walking before. And then the next one is a new one, and it's 10, not attempted due to weather constraints or lack of equipment. So that could be, I'm thinking especially the item about walking up uneven surfaces like up a hill on turf or gravel. I might not want to take someone out in a raging thunderstorm or a hurricane. For those of you in Florida, they would not be good times to take somebody outside and try to make them walk up a hill. So if we can't do it because of weather or because we don't have the equipment, like in a car transfer, then you can put the number 10. And then the 88 we're pretty familiar with. We didn't attempt it due to medical condition or safety concerns. So again, on my admission nursing assessment for someone with a fresh hip fracture, I wouldn't think as a nurse it would be safe for me to transfer them, make them stand up, try to walk. For me, I would be putting 88, but the physical therapist doing the assessment might be able to have them stand up and might be able to attempt them to walk a few feet. And so there might be differences between the two, and that's where that interdisciplinary team comes into play, where we're actually nursing sees one thing, therapy sees another. Now we're going to decide together what is their usual performance. So when you're making your coding decision, they want you to follow the algorithm. Does the resident do it completely by themselves with no physical, verbal, nonverbal cueing, setup, cleanup? If the answer is yes, it's dependent. We didn't need to come to work today, they're a 6. If that's not the case, did the resident need only setup or cleanup assistance from one helper? If yes, it's a 5. If no, if they needed more than that, did they need just verbal or nonverbal cueing or a steadying contact guard assistance from a helper? If yes, it's a 4. If no, did they need someone's physical assistance for lifting or supporting the trunk or limbs? If yes, if the resident did more than half and the helper did less than half, it's a 3. If the helper did more than half, it's a 2. If the resident didn't help at all, or we had 2 helpers, even if it's just for safety, they're a 1 for dependent. And then we have the 4 options for activity was not attempted. So every time you're making your assessment decision, use that algorithm to decide. All right, whoops. So what documentation, I'm going to make sure I didn't miss a slide, sorry. So what documentation is required? Well, documentation in the medical record has to be there to support the coding of GG. And data entered should be consistent with the clinical assessment documentation in the resident's clinical record. And this assessment can be conducted by appropriate healthcare, those who can assess. And remember, this information will dramatically impact payment. And anytime there's a payment item, we have to make sure that in the medical record, anyone looking at this record would come to the same coding decision that we do. And the assessments do have to be documented during that 3-day assessment window. So these are the ADLs that will, or the functional items that will affect payment in PDPM. Eating, oral hygiene, toilet hygiene, sit to stand, lying to sitting on the side of the bed, bed to chair to bed, transfers, toilet transfers, walking 50 feet with 2 turns, and walking 150 feet. So let's talk about eating, because it's different than section G. So in eating, it's the ability to use suitable utensils to bring food or liquid to the mouth and to swallow food or liquid once the meal is placed before the resident. So it's only talking about using suitable utensils to bring food or liquid to the mouth. So it's not talking about tube feeding or IV fluids like we can count in G. It's only talking about eating and drinking by mouth. So they need an assessment of how well they can eat and drink by mouth. And if they do have a tube feeding or TPN, and they also do get something by mouth, you only count the assistance needed to eat or drink by mouth. And it says suitable utensils, so if they're eating a sandwich and picking it up with their fingers, that would be a suitable utensil, but I'm thinking if they're trying to eat their soup with their fingers, it's not a suitable utensil. So if they have a tube feeding, they're 100% tube fed, the tube feeding is new, then I would code in 88 because I can't include tube feeding or TPN as part of eating. If the resident has been on a tube feeding for years and has not had anything by mouth before the most recent illness or injury, I would code it as a 9, not applicable. And if they have part of their intake is oral and part of it's through the tube or the TPN, only count the oral intake when you're counting eating. So here's an example. The dietary aide opens all of Mr. S's cartons and containers on his food tray before leaving the room. So in other words, he needs somebody to help open things. Maybe he has arthritis in his fingers, but he can eat the meal himself, and we don't worry about his ability to eat, and so we go to help the next person. So how would you code his eating? Is he a 6? Did he do it all by himself with nothing? No setup, cleanup, partial assist? No, he's not completely independent, but he did feed himself by himself. He just needed help before he ate, which would be opening the cartons and the containers. So he would be a setup help, a 5. Oral hygiene also affects, and it's a major payment item for the PT and OT component, is the ability to use suitable items to clean their teeth. And if they have dentures, it's the ability to insert and remove dentures into and from the mouth and manage denture soaking and rinsing with the use of equipment. So again, we're looking at having the resident actually brush their teeth with suitable items. And if they have dentures, they have to get them out of their mouth and rinse them off and put them in the soaking solution and rinse them off when they get them out and put them back in their mouth. Can they do all of that all by themselves? And CMS has actually put in the manual, if the resident doesn't do oral hygiene during therapy, then determine their ability based on performance in the nursing care unit. So what is this talking about? Well, therapists are often extrapolating how well the resident can brush their teeth by their abilities to do other things. But this is a major payment item. It pays as much as eating and toileting and all of those things. So this is a payment item. We don't have it as a payment item right now, but it's important that this is actually done as an assessment. All right, so here's a poll question. And I don't think we talked about this. Is this set up that we can do a poll question?
Yes, please just go ahead and read the question, and then we'll go to the next slide and launch the poll.
All right, thank you. All right, at noon on day 3 of the Part A stay, you asked your OT, your occupational therapist, if he had assessed how well the resident could brush her teeth. The therapist stated that he didn't actually have the resident attempt to brush her teeth, but he was confident that she would be able to brush her own teeth based on her ability to brush her hair and wash her face. So the question is, what would be the appropriate next step? Would you code them as independent for oral hygiene, 88, dash it, or assess the resident on the nursing unit?
Great, so if you'll just take a moment to select your answer, we'll give you guys just a few seconds to respond to that, and then we'll launch the results in just a moment. Well, thanks to everyone who has gone ahead and selected an answer. I'm just going to give you a couple more seconds, but the majority of people have just about responded, so just one moment. Okay. All right, I'm going to go ahead and close out our poll. And here you can see the answer. So we did have the majority of folks answered assess the resident on the nursing unit.
Okay, and great. And that was the correct answer. Some of you wanted to code the 88 for oral hygiene. Oral hygiene does need to be assessed on the nursing unit. And so often when I'm looking at the therapy evaluations, not all of the items that, so usually it's OT that's doing the self-care and PT doing the mobility, but they don't have the opportunity often during the evaluation to test every one of those items. So that's why we have to make sure. For example, one of the items that is under self-care would be shower and bathing. And during an OT evaluation, most likely they are not taking a shower during the evaluation or are giving them a complete bath. So we have to make sure that these items have been actually assessed. All right, do I have the, there we go. There we go. I'm having trouble getting the slides to go again. All right, so, okay, now we're back on track. All right, toilet hygiene is another payment item, and this is the ability to maintain perineal hygiene, adjust clothing before and after voiding or having a bowel movement, and if managing an ostomy, it includes opening, wiping the opening, but not managing the equipment. And again, it could be the hygiene, it's adjusting the way that they're counting it is pulling the resident's clothing down to prepare for voiding is a third, pulling them back up is a third, and doing the hygiene or the wiping is the other third. So again, we're talking about managing undergarments and clothing, incontinent products, and for performing the perineal cleansing before and after voiding or having a bowel movement. And it can take place before and after using a toilet, a bedpan, or a urinal, or it could be incontinence care. And if the resident doesn't usually use undergarments, then assess their need for assistance to manage the lower body clothing. And if they have an indwelling urinary catheter and has bowel movements, code the toilet hygiene based on the amount of assistance needed by the resident when moving his or her bowels. And here's another issue I'm concerned about in those first 3 days. We have to make sure that a nurse or a therapist is assessing the toilet hygiene, and if they have an indwelling catheter, that could be a little problematic to get that accomplished. Sit to lying is now part of the bed mobility quality component of the functional score, and it's the ability to move from sitting on the side of the bed to lying flat on the bed, and the other is lying to sitting on the side of the bed. This is the ability to move from lying on their back to sitting on the side of the bed with their feet flat on the floor and no back support. And again, this is an assessment that we have to make sure that they can get their feet flat to the floor. All right, and it says if their feet don't reach the floor, then you can lower the bed, or you could bring a footstool. But in order to actually assess this, they have to be able to have something to put their feet on so they can hold their back up. So clinical judgment should be used to determine what's considered a lying position for a particular resident. And if you have to keep the head of the bed up, maybe because they have COPD and they can't breathe flat, you might have to say that it's 88. I can't attempt it. It's not safe medically to put them flat to test this. And also when we're talking back support, it refers to an object or a person providing support for their back. So can the resident actually sit up if their feet can touch the floor, and can they hold their back up without needing a person or an object to support their back? So those two items are used for the bed mobility component of PT, OT, and nursing. And then sit to stand is the ability to come to a standing position from sitting in a chair or a wheelchair or on the side of the bed. And again, if they need a sit to stand lift and it takes two helpers, then it would be dependent, because anytime there's two, it would be considered dependent. Chair to bed to chair would be the ability to transfer to and from a bed to a chair or a wheelchair. And again, it starts with them sitting in a chair or a wheelchair or the edge of the bed, and returns to sitting in a chair or wheelchair or upright at the edge of the bed. And if you use a mechanical lift and need 2 persons, again, it would be dependent. Toilet transfer is the third. So these 3 transfer items are averaged together to give you a transfer score for PDPM. And this is the ability to get on and off a toilet or commode. Then there are 2 walking items that affect the payment in PDPM. It's the walking 50 feet with 2 turns and walking 150 feet, but there's a gateway question that says walking 10 feet. Once it's standing, can the resident walk 10 feet in their room, corridor, or similar space? If they can't do that, it skips the walking items, and then everything would be coded as an 88 or whatever the reason for the inability to walk the 10 feet. But if they can walk 10 feet, then it's going to open up the walking 50 feet with 2 turns, and the 2 turns do need to be 90-degree turns, and then walking 150 feet. All right, so these are the items, and so the GG code you can see on the left. So if they're independent or independent or setup, coded 5 or 6, you get a score of 4. If they're supervision or touching, so the GG code is a 4, you get 3 points for the score for the functional performance. If there are 3 for partial moderate assistance, you get 2 points. 2, you get 1 point. And if they're dependent or the activity did not occur, you get 0 points. So adding that up for your score. So again, we're looking at these items, and you'll see on the right-hand side that eating, oral hygiene, and toilet hygiene are individual scores. So you're going to get a 0 to 4 score for those items. But for the 2 bed mobility items, you're going to average the 2 together, and it might be a decimal. I mean, it might be a fraction, but you just keep that until the end, all right? And then we're adding together the 3 transfer items, sit to stand, chair to bed, the chair, and toileting, and then add them together, divide by 3 to get the average of those scores. And then the 2 walking items, again, you're going to add together your PDPM functional score, average those 2 together, and it's the average of that. Add them all together, and at the very end, now you're going to round up if it's 0.5 or higher, round down if it's 0.4 or lower when you're adding all of the decimals together if there were any partial scores because of the averaging. You can see that's why that oral hygiene is so important. It counts full amount like eating and toilet hygiene. So it's not averaged like the bed mobility and transfer and walking items. So here's an example. Mr. Doe was admitted from the hospital after experiencing a left femoral neck fracture, which was repaired with a total hip replacement. During the first 3 days of his stay and before treatment was started, he was unable to walk. He needed total assistance with sit to stand and chair to bed to chair using a Hoyer lift, and toilet transfers weren't even attempted. He required substantial maximal assistance with toilet hygiene. He could brush his teeth after he was set up, eat independently, and needed substantial maximal assistance with sit to lying and lying to sitting on the side of the bed. So his GG coding for eating was a 6, his score is 4. His oral hygiene was a 5 for setup, his score is 4. Toilet hygiene, he needed a substantial maximal assistance, he gets a GG score of 2. We get 1 point towards our PDPM score. And then for the 2 items, sit to lying and lying to sitting, he was substantial maximal for both. 2 plus 2 is 4 divided by 2 so 2 plus 2 is 4. 4 divided by 2 is a 2, and a score of a 2 gives me 1, all right? And for the 3 transfer items, we have a 1 and a 1 and a 0, so we have 2 divided by 3 is 0.66. So we're going to add them together. There was no walking, we have a score of 0. So 0.66 is less than 1, 1 gives me 0, and so we have a total score of 10. So again, the way I look at these, so if my score for the coding is a 1, I get a 0. If it's a 2, I get a 1. So you just subtract 1 from the actual GG code, except for the 5 and the 6. So if it's a 6, it's going to be a 4. If it's 5, it's going to be a 4. But a 4 will give you a 3. A 3 gives you 2. So if in my head, I'm just doing that. So if I'm dividing and I get a 0.66, it's going to be round up to a 1. I get a 0 for a 1. So his score is a 10. So when I look at the PT and OT component, he had a major joint replacement, right? And his score was a 10. So it gives him a TC. So when I'm looking at the payment, so major joint replacement, score is a 10, and his PT component is going to be 1.88, and his OT is 1.68. Now this was done before the PPS proposed rule came out, and the OT is now a 1.69 instead of 1.68. But just so you can, here's Mr. Doe. All right, so let's see how that affects your payment. So he's a TC, and he's a 1.88. If I just use the federal unadjusted rates, the PT component score payment is $61.16. And so I take that, whoops, so it looks like I haven't redone that. So this was before they updated the payment. So before the proposed rule came out, the payment component for PT was $59.33 a day. 1.88 times 59.33 is 114, and 1.69 times the 56.93 was 95.64. So what you would do to get the true rating, it looks like I just messed up with the PT. So you should take 1.88 times 61.16 to get the PT component, and for OT, it's 1.69 times 56.93, and adding them together, we have $210.63. Okay, so I have taken the components for the federal component, and I've taken the wage adjustment for Orange County, Florida, and Miami-Dade, Florida, to show you your basic base rates, because we're taking it times the actual federal rates, and these would be your adjusted rates for your county. So again, for Mr. Doe, the wage index for Orange County is 0.86. If I take his 1.88 times 5306, it's 99.65, and times the OT base rate of 49.39 times 1.869, it's $83.47. So that's the idea of how to figure out what you would be paid depending on the component score. Now I'm going to move into the nursing component and how GG affects that. We have the same nursing case mix groups that we have right now, except they have smushed them down into 25 case mix groups. So what they've done is they've pushed the ADL bin scores together into bins, they call it. So the A score is, if the ADL score is 15 to 16, but they've now call it BC. So they're adding the B score and the C score together. So if score between 6 and 14 will give you a BC component. And if the resident is really dependent and the score is 0 to 5, you'll get a DE. So if we're looking at this, these are the nursing GG scores that affect them, you'll see that we don't have the oral hygiene and we don't have the walking items, but it has all of the rest of the items are the same as they were for PT and OT. So we have eating, toileting, and then it's going to average the 2 bed mobility scores together and the 3 transfer scores together, add them up to get your final score. So for example, if eating was a 6, we would have 4. If toilet hygiene was a 2, we'd have 1. Sit to lying was a 3, it would be worth 2. Lying to sitting on the side of the bed was a 2, we get 1. We have nothing for the sit to stand. We have a 1 for the chair to bed, the chair, and 1 for the toileting. So if we're going to look at our final function score, the eating is individual, so we get all 4. The toilet hygiene is individual, so we get that one. For the sit to lying and lying to sitting, it's going to take the 3, 2 plus 1 divided by 2 is 1.5. And then for the 3 transfers, we add them together, all right, and we have 2 divided by 3 is 0.66. And now I add it all together, and I'm going to get, because I'm adding my decimals, and I don't do it to the very end, then I get 7.1. I'm rounding to the nearest integer, which is a 7. All right, and so when we look at the nursing components, you'll see that it says HDE2, HBC2, HDE1, HBC1. So they're putting those scores together, so scrunched together. So the score of 0 to 5 is a DE and 6 to 14 is a BC. But all of the components of the nursing services are the same as now. And then you can see on the right-hand side, so I look at my GG functional score, right? 0 to 5 and 6 to 14 for my DE, my HBC2, my HBC1, and then on the far right, it's what we're going to multiply. It's the case mix index times the base nursing component rate. So that GG really affects the final payment. So Mr. Doe, he had his total hip. So he had a surgical wound, and he had an active diagnosis of type 2 diabetes, and he needed daily insulin. He has diabetic retinopathy, and he qualifies for a clinically complex category related to a surgical wound, and his PHQ-9 score was 10, which meant he was a little depressed. His ADL score was 6, and so he's going to qualify for clinically complex with a CBC2, which is 1.55 times the nursing base rate of $106.64 a day, which will give you $165.29 per day based on his functional score. Now, just for fun, if he was totally dependent, still with depression, all right, so he would be CDE2, and we would get $199 a day because that case mix is 1.87 times 106.64. So we would make $34.13 a day more than the CBC2 payment. So again, in this case, in the nursing realm, the more dependent, the higher the score for each of the nursing components. So when you're looking at what kind of documentation should support your GG, I think there does need to be a little bit of narrative. I think for a reviewer, just seeing a bunch of numbers wouldn't really show what the resident could do. And so this is an example of Mrs. Stevens could feed herself, but due to weakness, the staff had to open containers and cut her meat. She could feed herself slowly. She's a 5. For oral hygiene, he has dentures. She has dentures, and she's too tired to brush her dentures. She asked the staff member to help her with her teeth. She could take them out of her mouth and hand them to the staff member, but the staff member had to do the process, and then when they handed them back to her, she could put them back in her mouth. So Mrs. Stevens didn't do half. The helper did more than half, so she's a 2. On a toilet hygiene, she used a bedpan only on the day of admission. She could pull her gown up, but the staff member had to do the hygiene and pull her gown down. So the staff member did more than half. It would be coded as a 2. So I think you need something like that. So managing the process, I would make sure I had these GG items on either the admission nursing assessment, so my nurse who's doing the admission is doing it, or having a separate functional assessment that you trigger to be done within the first or second day of the Medicare stay before the resident is starting to improve with our care. So we need a nursing assessment. Not everybody has therapy, and not every item is assessed in therapy. So the nursing assessment needs to be done. And then the therapy evaluations, I believe you should be looking at your therapy evaluations to see if they have specifically included these GG items, that they're actually having a little documentation of what the resident can do with those GG items, that they're only including those actually assessed and not just that they've extrapolated or used their professional judgment about. And then make sure that your therapy software does not include extrapolated responses, and that the MDS coordinator is not just importing the responses from the therapy software into the MDS without ensuring that those items were assessed. And I think that to manage the process, we'll have nursing assessments, we have therapy evaluations. Ideally, therapy and MDS at a minimum would meet daily for those brand new admissions within those first 3 days and compare the responses from the nursing assessment and the therapy evaluations, and talking about only the items actually assessed, and come together, coming to a conclusion about what is the resident's usual performance to be coded on the MDS within that first 3 days, and also again at the last 3 days of the stay. It takes a team, and there should be documentation that this is all happening. Then there should be an audit. So to make sure this is done, audit your assessments and documentation of the resident's function during the first 3 days and the last 3 days of the stay, and also during those 3 days in IPA assessment window if we're doing IPAs. Educate your admission nurses and all evaluating therapists about the importance of accurate and timely assessment and how to clearly document the functional status of the resident. And remember that during that first week in October, that you're going to have the team all ready to go to do GGs on everyone who needs an IPA during those first 7 days of October. And so that brings us to the end of today's presentation. Thank you very much.
I want to thank you, Carol, for that wonderful presentation. Just want to give you a very big thank you to Carol Maher, Director of Education at Hansen, Hunter & Company, Certified Public Accountants. We very much appreciate your time, Carol, and your commitment to sharing this information. Just before we conclude, if you do have follow-up questions, you can type them into that question box now, or you can email me directly at motiska@fhca.org. We will follow up with a Q&A document and make available the responses and the questions to all of our attendees on the website with the webinar recording. And finally, a big thank you to our title sponsor, MedPass, and our supporting sponsor, Thrive Behavioral Sciences. And as always, we thank you for attending today's webinar and for your work to provide person-centered care in Florida. This concludes our webinar. Please have a great day, everyone.